to bridge the gap between patient identification. And so this protects the patient during those waiting periods, and they are either 40 days or 90 days depending on if they've been revascularized or not. So rather than send them home with nothing, they can wear this, and it is an external wearable cardiac defibrillator. It's the only one on the market, and I just want to show you how it is worn so you can understand. It's worn obviously under the clothes, but I didn't want to do that for you today. And it hooks just kind of like a bra in the front here. There are 3 hooks. And so that's how you're going to remove it, is just by undoing the hooks. Just like that. So they have a therapy pad in the front, and then 2 in the back, and then 4 leads that read side to side, front and back for rate and morphology. It's only looking for VT and VF. So what does it do if it picks up on VT or VF? Well, they have to be at 150 or somewhere around there, depending on if the physician changes the thresholds. But typically it's a 150 VT and 200 VF. And this will treat in 60 seconds for VT and 30 seconds for VF. You may hear some alarms if they are, in fact, in VT or VF. We train the patient before when we deliver this to them, how to respond to the sounds. So I just wanted to play a couple of the, I don't know if you can hear that. That's a gong alert, okay? It's just telling them that something's going on with the belt. So if you hear that, it's not going to shock them. Let me get to the siren. But anyway, we train them so they know how to respond to the gongs and the sirens. So if they were to go into VT, a siren alarm will go off, and then it will be treating them within 60 seconds if they don't respond. There are 2 response buttons, one on the back, one in the front, so if they were to fall, they wouldn't stop a treatment. It's typically worn for between 30 and 90 days, just depending on the patient's indications and if they've been revascularized. The main thing that I wanted to tell you about is how to take it off, because if you cut this, typically if they do have an event, they will be going home from the ER in this, okay? So if you cut it, then they have no way to go home protected. So when you see someone wearing this, just unhook it in the front. Some counties, they leave this on during transport, but those are rural counties that, if they're way out. So some counties leave it on, some hospitals leave it on the patient. But I'm assuming you guys would take this off and put your own stuff on it. Right before a treatment is delivered, I just wanted to show you the siren alarm. It's really loud, so you'll know if they're going to be shocked. And then it also has voice prompts, just like in AED. So it'll say, don't touch the patient, a treatment is about to be given, a treatment has been given, please call 911. So it'll tell you what's going on as it's doing its thing. Right before a treatment is given, blue gel gets deployed out of these pads to reduce burn and increase conductivity. So if you see blue gel on a patient, you know they've had a treatment. That's really the only way to tell. So you see the blue gel, they did have VFib arrest, and they most likely were unconscious because they would have pushed the buttons if they weren't. Do you guys have any questions? It's pretty straightforward. Mark passed these out. These are just little cards that kind of tell you what the tones and sirens mean and what to do. But basically, if the siren's going off, you can leave it on and let them get treated and then take it off and put your stuff on. It has a 99% first shock rate conversion and a 98% survival rate for that sudden cardiac event. It's 150 joule biphasic treatment. It's really effective, and we save about 70 lives a month across the nation. So it's not a huge population that gets this. It's a very specific, high-risk, low ejection fraction patient that would get this. But it does save their lives, and don't cut it off. One other thing I wanted to show you, the way you turn this off, there's no off button. It's just removing the battery, and it just comes out. There are 2 buttons on the side. You just pull it out, then it's off. It won't shock in the air. Like if you take the vest off and it starts gonging, it's not going to shock you. You can never generate a treatment. You can only stop it by pressing the button. So don't be afraid of it. That's it. Yeah.
Okay. Today we're going to talk about spinal trauma, and I will use that to launch into sort of a discussion of the not new, but the sort of way that the American College of Surgeons and the National Association of EMS Physicians is approaching spinal trauma and spinal immobilization. There's a lot of controversy. You're going to find places in the state where they're going entirely away from long backboard. Oh my God! Next, we'll take away amiodarone and epinephrine, right? That might happen too. But we'll talk about. We're not going to take that entirely away. And actually, we've been pretty good with our spinal immobilization algorithm for many years, and I'll tell you about that too. So, spinal trauma. We got 33 bones in the spine, which is the same basically for almost all mammals, including giraffes. They still have the same number of bones in the spine that we do, particularly in the cervical spine. They just have longer ones. It functions as the main skeletal support structure of the rest of your skeleton. It's called the axial skeleton. So it's the axis of the skeleton. And it provides a protective container for the spinal cord. Vertebral bodies are the major weight-bearing components, and they're anterior to the other vertebral components. So the spinal cord is behind the vertebral body. So a vertebra consists of the spinal canal, the pedicles, which are foot processes, the lamina, the transverse process, the spinous process, and many of the vertebrae don't have significant spinous or transverse processes, as we'll see. There are discs, intervertebral discs between each vertebra, and the disc is made. It's got a thick fibrous fibroelastic coating around it, and it's sort of a gel inside it, which provides cushioning. As we get older, that gel and the discs sort of lose integrity, and they begin to sag and squeeze together, and that's where you get what we call disc narrowing. When you go into the physician and say, my back hurts, and take an x-ray and say, yeah, your back's getting old. It's the discs are compressing, and sooner or later the discs almost disappear and the the bones begin to touch. There's a large vertebral ligament anteriorly and a posterior longitudinal ligament as well, connecting the vertebral bodies together. That provides the secondary support structure for the spine. It allows, the spine has flexibility, both anterior, posterior, and lateral, and as well as some rotation, at least in the cervical spine. And these vertebral ligaments are rather important, because in children, you often get what's called the Sawara syndrome, which means you've got spinal cord injury without X-ray evidence. You don't have any bone injury, but you've broken the spine because the ligaments have been disrupted. We get fractures in adults that do or don't disrupt those ligaments, and that makes a significant difference to the patient outcome, because if the ligament has been disrupted, it means you've had a tremendous force, and usually it compresses the spinal cord. Even if there's not a fracture into the cord has been injured. So this is what your vertebral bodies look like. So you got your 33 all the way down here. These are fused in the sacrum, and in the cervical spine, they're much thinner, smaller. You've got these lateral foramina, where the vertebral artery goes through. Rather large space for the cord in the cervical spine, and we'll look at the cervical spine in more detail in a minute. These are the lamina. These are the wings that put the spine together posteriorly to surround the cord, and this, of course, is the vertebral body. Vertebral body is very small in the axis, or the atlas, because it's it's made to be lightweight and to provide rotation at the head. Very much larger in the lumbar vertebral bodies, because they're mostly weight-bearing. So the cervical spine is made up of 7 vertebrae. It is the sole support for the head. Head, depending on how much you've got in there, weighs between 16 and 22 pounds for the average adult. You can see there's some fair difference. C1, the atlas, supports the head, is fixed to the occiput, but provides rotation and nodding kind of thing. The axis, which is the second cervical vertebral body, has a funny little process that sticks up in the middle called the dons, or dens if you want to pronounce it American way. And it's the pivot point so you can rotate your head. It's also the nasty thing that if you end up hanging somebody, or you have a fall which smacks the head back, pushes the dons forward, that dons actually severs the spinal cord, which is what kills you in a proper way of hanging rather than just choking to death. I know it's important to you to know which way you're going to die. C7, the seventh cervical vertebra, typically is what's called, also has the largest spinous process, the thing that sticks out in back. And that's what you can feel in the back of your neck when you feel the most prominent thing. That's usually the 7th cervical vertebra spinous process, called the vertebra prominens. Now, some people have the first thoracic being the most prominent one. That's just a normal variation. Doesn't mean there's anything odd. There's a chiropractic text out there that has a very nice description of the 8th cervical vertebra, because there are 8 cervical nerves, and you have to know that there's a vertebra for every nerve, but that's not the way it works out. The first one comes out above the atlas, so it doesn't really count. So this is what the atlas looks like. Again, very, very thin, very lightweight, easy to fracture. Fractures all the time, but there's the nice thing about it is there's a huge room in here for the spinal cord, normally. It's the whole point, because you've got nodding and rotation here. Now, this is the don sticking up from C2, so this fits in this slot right back here, and there's a ligament that holds it together, but it's not super tough. It can be disrupted, and it is disrupted and falls all the time. This shows at least C1 through three all together, and this is the articular facet for the occiput itself, and you can see how they all nicely fit together. I think there may be another picture, yep, that shows all the vertebral artery comes up and goes through that little foramina all the way up, dives in right here where the occiput and the atlas come together, and that feeds the posterior circulation of the brain. This longitudinal ligament here, there's also some ligaments in between each of the vertebral bodies, and posteriorly you can see how all these spinous processes stick out. There are ligaments between them. If you break a ligament or break a spinous process, it's a painful thing, but it doesn't usually have any neurologic symptoms. Now, the thoracic spine, much tougher, much less mobile, 12 vertebrae. The first rib articulates with the first thoracic vertebra. It attaches both to the transverse process and to the vertebral body. The next 9 ribs attach to the inferior and to the superior portion of the adjacent vertebral body. So it attaches, the rib attaches to one vertebra above and one vertebra below. That's how the ribs articulate. This limits rib movement, but it provides rigidity for the thoracic spine and the thorax itself. They're bigger, they're stronger, they have a lot more muscles around them to help support, and they also have the thoracic muscles of the muscles between the ribs. It helps to stabilize it so they can elevate the chest when you take a breath. So this is what these guys look like. Much bigger, much more solid. You notice they don't have any foramina on the side because they don't have a vertebral artery is already stopped. It's only a cervical phenomenon. They have really big pedicles here, the lamina, which are going to support the ribs. And this shows then the rib articulating to this vertebra and articulating to this vertebra below it. So it's a double connection there. Sometimes in injuries, and chiropractors are pretty good at dealing with this one, sometimes a rib will actually disarticulate from its connection, and actually it can be manipulated back into position. It's not something physicians generally do, but it can be manipulated. I've seen it done. The lumbar spine, 5 vertebrae only. Now, they bear the forces of bending and lifting above the pelvis, and so they're bearing the entire weight of the cervical spine and the head and the thorax and the abdomen. They're the largest, thickest vertebral bodies, and they have the biggest intervertebral discs, and they're also the intervertebral discs that fail the most commonly because they have all that downward pressure on it, gravity and everything else. So these are really big, chunky things, and they articulate with each other all the way down. The intervertebral disc is very big, and ordinarily this is bigger than the first lumbar. So they get progressively larger, the discs, as they go downward normally. That's what we look for on an x-ray. The good old-fashioned days, all you got was an x-ray. We say, oh, you've got a intervertebral disc collapse at L4-5, so that's probably where your back pain is coming from. Now we have much fancier things. They have MRIs and CT scans, and they cost you about $4,000 instead of $400, and we tell you, yeah, you've got a intervertebral disc that's collapsed. Same difference, only it's better, right? Notice that the spinous processes are quite large in the lumbar spine because there's muscles attached to these things to help you bend and straighten up. So they have to be really strong. Sacrum is 5 fused vertebrae in most people. Now sometimes the first sacrum fuses also with the fifth lumbar, and that's called sacralization of the fifth lumbar. And then sometimes the first sacrum is separate from the, it looks like a sixth lumbar vertebra. It's a normal variant. It's called lumbarization of the first sacrum. So it's just, everybody's different, and that you just, some people have what appears to be a longer spine than other people, but they're the same number of vertebrae ultimately. The sacrum, though, is fused together. It's the posterior portion of the pelvis. It's protective. The sacrum and pelvis is there to protect your pelvic organs. And it also attaches the pelvis and lower extremities, of course, to the axial skeleton. Then the coccyx has 3 to 5 fused vertebrae. Now, some people have 5, some people have 3, but they're supposedly going to be all 5, but they're just fused. It is the residual elements of a tail for all intents and purposes, and the only important thing about the coccyx is it makes it causes a lot of discomfort if you fall on it and break it, because there's not much you can do about it. And tincture of thyme often treats it, but it's kind of annoying. So this is what the sacrum looks like, and you see they're left over. They've got the sacral foramina that would allow nerves to come out through it. Your coccyx, in this case, is 4 fused vertebrae. They're together as well. So just a big block. Now this can be broken occasionally with a direct blow, usually a fall from a height. You can land it and fracture the sacrum. Yeah. Now, as I said earlier, the spinal cord goes down through the spinal canal through the vertebra. Spinal cord actually ends at the level of the usually L1, and then all the various nerves of the sacral cord separate out in what's called the cauda equina, or the horse's tail. So you don't have solid spinal cord at that point. You have individual nerves that are coming out in a fan-like fashion out of the spinal cord. Around the spinal cord is just like the brain, is trapped in layers of meninges: the dura mater, the arachnoid, and the pia mater. The pia mater produces the cerebrospinal fluid, and that fills the subarachnoid space of both the brain and the spinal cord. So that normally the spinal fluid circulates through the brain and the spinal cord. Now, when we do a lumbar puncture, which we still do, to diagnose meningitis or other potential spinal cord infections, we insert the spinal cord needle at about the level of L2 or 3, because we can get in there without hitting the cord. You can enter the dura mater, get into the spinal fluid, and you don't hit the spinal cord because it's stopped at L1. Now, your cord, spinal cord, is the anterior medial fissure, which is a big crease along the ventral surface of the spinal cord. Divides the cord into the right and left half, just like there's a crease in the brain that divides the brain into the right and left half. There's a posterior medial fissure, which is a little groove along the dorsal surface. The gray matter, the central portion of the cord, is gray matter, which is actual nerve cell bodies. There are actual nerves starting in the gray matter, just like the gray matter of your brain is where the nerves start of a brain. That's the central portion of both the brain and the spinal cord. The white matter is all axons. They're nerve fibers, but they're not the neuron. They're not where the cell nucleus is of that nerve. So this is the cord at various levels. And you can see there's a lot more in the cervical spine, a little less in the thoracic spine, a little bit more low down in lumbar spine, and the difference in sizes of the gray matter and the white matter. This is what we were saying. This is that big central fissure that divides it in half, and then there's the ventral one. So this is dorsal and this is central. So this is toward the back. This is toward the front. Axons, the nerve bodies, the nerves themselves, what we recognize as nerves, transmit signals upward to the brain and or downward to the body. They're basically one-way tracks. They have ascending tracks that send the signals to the brain from the spinal cord or from the body, and these are the sensory tracks. You have descending tracks, ones that are going downward, that transmit signals to the body from the brain. And you have motor tracks that are voluntary and fine muscle, and you also have tracks that start in the spinal cord, in that gray matter, that control the reflexes. Because the reflex is a short circuit. It's a short circuit, not a short circuit, but it's a short circuit. You have an impulse coming up from the extremity, such as you touch a hot iron, and it would normally go up to your brain and say, hey, you just touched something hot, and if this was all voluntary, then you would send a message down to the brain to take your hand away from the hot iron. That takes a little time, and a much quicker thing would be to have the reflex, which it does work, goes up to the spinal cord, sends that message upward that says, hey, you just touched something hot. So you know that you touched something hot, but you pull back from it because it communicates at the brain, at the spinal cord in that gray matter. The gray matter sends a message down to the muscle, pull back from that hot thing, without you thinking about it. You don't have to think about pulling back from something hot. You notice it's hot after the fact. So that's the reflex, and that happens. So those are ascending tracks that go up to the spinal cord and then further on up to the brain, but they also immediately hook to a reflex mechanism that sends a message to your muscle to react. So this is a chunk of spinal cord diagrammed out, and the important things are that the things in blue, the nice pretty blue, these are ascending pathways. These are pathways that are going up to the brain. So they are sensory pathways. They're going to, and the sensations are going to be pain, deep pain, light, if you hear such a thing as light pain, pinprick kind of pain, heat, cold, vibration. And these primarily, so these will come up, and depending on where you are that's why the cervical spine will have, the cervical spinal cord looks bigger in section because it not only has ascending tracts that are coming from the lower extremities, but now it has a huge amount of sensory tracts that are coming from the upper extremities. So it swells the cord out of that space. This is one of the reasons why you have a larger spinal canal at that point, is to accommodate that cord. Now, the red things, although they would occur over here as well, they don't just occur on one side, obviously. This is a schematic to make it easier to see. These are the descending pathways. These are motor pathways that are coming down toward to whatever lower extremity or upper extremity muscles that you have voluntary control over. Notice that the motor things are closer to the center of the cord. That's important because we'll talk about a thing called the central cord syndrome, which is kind of a squeeze of that. The cord gets crimped, gets pinched, and you lose motor control, but you maintain sensory control. Now, spinal nerves. There are 31 pairs of nerves that originate along the spinal cord from anterior and posterior nerve roots. They both have sensory and motor functions. They travel through the intervertebral foramina as they come out of the cord and go through the intervertebral foramina and then go down to whatever organ or muscles that it's innervating in the skin. The first pair of exit between the skull and C1. The remainder of each pair exit below the vertebra. So C1 has, first cervical one comes out above it, C2 comes out above C2 but below C1. And that's the way it works from the way down, which is why the chiropractic ended up with the C8 vertebra, because they knew that they were supposed to have one, but they don't. Each pair has 2 dorsal roots and 2 ventral roots. The ventral roots send the motor impulses from the cord to the body. The dorsal roots transmit the sensory impulses back from the body to the cord. C1 and coccyx 1 don't have dorsal roots. There's no sensory fibers in C1 and no sensory fibers in coccyx 1. There are all these nerves that are coming out of the spinal cord through the foramina. They rendezvous in various areas in a cluster of nerves. A cluster of nerves is called a plexus of nerves. 5 cervical nerve roots go together to innervate the neck, and they also produce the phrenic nerve. That's important. The phrenic nerve is the nerve that supplies the diaphragm. So that's what allows your diaphragm to function normally. So if you have a cord injury at somewhere between C1 and C3, that's where you're likely to get phrenic nerve paralysis, and that we all know that people who get a cord severed at C1 or C2 stop breathing, and they usually die from that. That's what happens. That's where your diaphragm is controlled. The brachial plexus is made up of the nerve from C5 through T1. They come together in a plexus that innervates your upper extremity. So the neck is innervated by the peripheral roots C3 through C5, but C5 through T1 controls your muscles of your upper extremity and also provides the sensory portion. The lumbar and sacral plexus comes together at, so L1, 2, 3, 4, 5, and S1 come together to make the sacral plexus, and that innervates your lower extremity, your bladder, your anus, etc. So, if you have a cervical injury at C1 through C5, and I don't think we put this on the test, so don't worry about it. Okay, cervical injury C1 through C5, your diaphragm is lost, you have respiratory paralysis. If your brachial plexus is injured, C5 through C8, and you can do that by injuring the neck, having a fracture in the neck, or injuring the brachial plexus in the armpit, deep in the armpit. Exactly, you end up with deltoid muscle paralysis, and as you work down the thing, if you injure the radial nerve, which is part of the brachial plexus, it comes off. The radial nerve supplies the basically the wrist. You'll end up with a wrist drop, end up getting the median nerve that gets your flexor muscles of your forearm, so you have weakness of the forearm, flexion. Musculocutaneous nerve comes out of there. If that's injured, you get once again decreased use of the hand. And if you injure the ulnar nerve, which just goes on the ulnar side, if that's in the plexus, you end up with a claw hand. You can't spread your fingers. Now, lumbar, T12 to L4. In the femoral nerve, lower abdomen, the gluteus, and the thighs, you lose the ability to extend the leg or flex the hip. Flexion of the hip is to bring the hip up like this. Extend the leg is what it is also to bring the foot up. So it's all the same. If you end up getting the obturator nerve, which is L2, 3, that gets the abductor muscles of the medial thigh, and abduction of the thigh is to move the leg out like this, away from the body. Abduction is to move away from the body. So you could do fine muscle testing on your patient in the field, but we go for the gross stuff in the field. Sacral, L4 to S3, that's the sciatic nerve, and you end up with a foot drop and decreased ability to flex or extend the foot at the ankle. And they always complain of, if they have pain involved in it, they complain of pain in the foot or the big toe. So what you need to know is just a couple quick things. And the term myotomes deals with the muscle and tissues of the body that's innervated by a specific nerve root. And you can sort of start from the bottom up and see if your patient, how your patient responds to if they're unable to flex the ankle. And flexing the ankle is plantar flexion of the ankle and dorsiflexion both. If they can't do that, they've got S1. If they can't extend the knee, their injury is at least at L3. If they can't bring their little finger into the center, and you can hold it, if they can't bring the little finger into the center, they've got T1. If they can't extend the elbow, that's C7. If they can't extend the entire arm, like that, that's C5. So somebody who's laying there paralyzed, they're breathing, they're still able to feel sensation in their neck, and they still have sensation above the nipples, but they can't raise their arm, they've got an injury at C5. You don't have to go down below that, beyond that point. And they won't be. If they have an injury at C5, they're not supposed to be able to move their lower extremities, but they might in one syndrome, which we'll talk about. So reflexes, I already mentioned this about, it speeds your body's responses to stressors, occurs in special neurons, the interneurons, which are the connection is at the spinal cord itself, so you don't have to take all the time to go all the way up and down the cord. So, but they're always damped by larger central nervous system cord. For example, we always talk about you hear the Babinski reflex, which is a normal reflex in people, normal reflex in children, but in an adult, if you stroke the bottom of the foot, and you usually use something like a tongue blade or something to rub up, you start at the heel and pull it up toward the big toe all the way. The normal response of an adult is to have downward movement of the big toe. That's normal Babinski reflex. But if you have, that's a reflex, and the reflex is damped by central nervous system control. If you've injured the spinal cord, or in some cases of stroke, when you do that Babinski reflex stroke, the big toe fans up and out, and the toes actually fan like that. But you have to look at the movement. The first movement has to, if it's up, that's an abnormal response. That's a normal response in children, babies, because they have not developed the central nervous system control of their reflexes. Now, more tellingly is to do is to check to see if they have clonus. Because normal response, if your ankle is laying down here like this, you pull up quick on the foot, you may get one beat, which is a reflex, because that stretch reflex of the Achilles tendon has gone up to the spinal cord, and then it sent a message down to jerk back in response to it, but then the brain damps that response. If you've lost that control of the brain now from a spinal cord injury, you pull up on the foot, you get sustained clonus. It'll just keep jerking back and forth on your hand like this. It's quite impressive. That means that their reflexes have been stopped. Now, that can also happen in strokes, can also happen in some neurologic conditions and some metabolic conditions. But we're talking about, life is pretty straightforward. If you go to the scene and you find someone laying there sort of looking paralyzed after a car wreck, you don't think that they've just had a stroke. That's the usual thing. Yeah. What caused the accident? Right. No, you don't always go there. Okay. Same thing can be done with patellar response. They'll get a continual jerk of the lower extremity. You can do it you can get clonus on an arm too. Very easily to test. Okay, now what also is in the spinal cord and spinal? Well, subdivision of the autonomic nervous system. We have parasympathetic system, the feed and breed, primarily the vagus nerve, but there's a couple of other nerves that are in the parasympathetic system. There are peripheral nerve roots from the sacral and cranial nerves that contribute to the parasympathetic system. The major function of the parasympathetic system, vagus nerve type thing, is slowing the heart rate, increasing digestive system activity. It does play a role in sexual stimulation, but that's probably not a big concern to you at the point of a car wreck either. Then you have the sympathetic side of the thing, the increased metabolic rate. Those are branches that come from nerves in the thoracic and lumbar region, and they're there to balance off, if you will, the parasympathetic side. Increase organ and digestive system activity, vasoconstriction, release of epi and norepinephrine, systemic vascular resistance, reduces venous blood volume, increases peripheral vascular resistance, increases heart rate, increases cardiac output. Okay, your primary, now you have, this is the dark blue ones, dark gray blues are the parasympathetics. And so you've got the glossopharyngeal, which innervates the tongue. You've got the vagus nerve, and you notice the vagus nerve gets a lot of work. It innervates, the pharynx, the trachea, the heart, the gut, and stops right about the level of the gut. Then you have this sacral pelvic ganglions, pelvic parasympathetics, and that innervates the bladder, etc. But these begin from ventral roots in the sacrum itself. The the sympathetic system starts out as branches off of the cord that go into nerve plexus, sympathetic ganglion, and they innervate the nerves directly. You've got the cervical one, you've got a ganglion that innervates the superior the stomach, innervates the small intestine, the large intestine, and then you have some branches that also contribute to the pelvic organs. Okay. Anyone want a break? Okay, let's take a break for a little bit. For 10 minutes. Pathophysiology of spinal injury. Well, first, extremes of motion. Hyperextension, hyperextending, or hyperflexing. Either way. Now, hyperextension is the most common thing, although I think we've got a case today that has hyperflexion. Excessive rotation, your neck can only rotate just so far, and lateral bending of the spine. Then there's axial loading, which is compression, so downward pressure. And that's common, most common between T12 and L2. There's distractional stress, axial loading, so that the two vertebrae will actually separate, and then a combination of distraction, compression, and rotation. Commonly, you see what are called compression fractures of the lumbar spine. So there'll be, you'll know it's a twisting injury because it'll be compressed on one side or compressed anteriorly. Other mechanism of injuries, obviously direct or blunt or penetrating trauma, electrocution caused by causing extreme muscular contraction can actually fracture. Most of the time, that's going to fracture spinous processes and lateral processes. So, examples of injury: flexion injury. So his neck is flexing forward. Compression or axial loading, diving injury. Recent death in Oregon from that, from diving into a pond and, of course, hitting the bottom. Distraction injury. Hyperextension, so whiplash. This is the whiplash injury, and the injury is primarily in the posterior muscle groups, not so much usually from the spinal cord itself. Flexion and rotation, twisting injuries can separate things, and then, of course, direct penetrating injuries. So now you get injury of the actual spinal column can be subluxation or dislocation fractures. You can just see here is the posterior element of the first or the atlas, and the axis is completely disrupted. You've got this long space there because this part here belongs right here. So that's a complete separation and dislocation of C1, C2. That is not a live person, particularly because there's no ET tube in them to ventilate them. So that's just a picture of a bad injury. The intervertebral disc rupture, and so the commonest site of column injuries is at C1, C2 because they're really delicate. C7 because that's a transition between a very flexible cervical spine to the less flexible thoracic spine. Very common also in older persons. people more than 70. T12L1, once again, difference in flexibility between the thoracic and the lumbar spot. So those are common sites of vertebral column injuries. What kind of injuries do you get to the cord? Well, if you can get a concussion, you just get a good whack. You know, that's James Bond whacking you on the side of the neck and getting a cord concussion. Temporary transient disruption of cord function, and that's about it. You treat that the same way we treat a regular concussion, by watching it. Contusion is a bruise. A contusion of the ankle is a bruise of the ankle. Well, you have a contusion of the cord. Actually, you have tissue damage, vascular swelling. You have edema, swelling of tissue because the integrity of the nerve body is lost, and you begin to leak fluid. You have compression secondary to the displacement of a vertebra, and commonly people have lumbar vertebral disc compressions that squeeze the gel and the capsule of the intervertebral disc the intervertebral disc is disrupted, the gel leaks out, pushes out. It's not, it's a pretty solid stuff, and it squeezes against the nerve root, causes pain, causes motor nerve problems. So that's a herniation of the intervertebral disc. The vertebra can be physically displaced. You can have a vertebral bone fragment that compresses the cord. I had a fracture of intervertebral disc, actually fractured a piece of the intervertebral disc off, and it compressed L4 and L4, L1 for me, which caused quite a bit of discomfort. You get a lot of swelling when you get back injury, and that can compress the cord externally. You can get a hemorrhage around the cord, which compresses the cord, all from injury. So here we have a burst fracture of C4. It's hard to tell with standard X-ray, but that's a burst fracture of C4, and you can see this whole vertebral body has got a burst fracture in it. This is the articulating surface of one vertebra above the other, so you're seeing two vertebral parts here. This is the body of the vertebra, and the fracture line runs through there. And the nice thing about this one is that's a safe fracture, because there's nothing in the back in that space. There's plenty of room for two spinal cords in there. So that's not a problem. That's just an uncomfortable fracture. Now, cord injury can actually lacerate the cord from bony fragments, the vertebral foramina, or stretching so far that it tears. Now, that would imply that not only the ligaments ruptured, but the vertebral bodies have separated enough during the injury to stretch and tear the cord. You can get hemorrhage then into the cord tissue, swelling, disruption of impulses. Usually lacerations will cause, if it's a complete laceration, everything is gone from below that point. If it's an incomplete laceration, it may just affect one arm, one leg, whatever. Hemorrhage can be associated with the contusion, the laceration, or stretching. And the hemorrhage, if it's under enough pressure, if it's arterial hemorrhage, it will compress the cord, and it can completely disrupt the cord function. There's a nice penetrating injury. It was pretty serious about sticking this guy. Obviously, you can see that goes right between the atlas and the cranial vault itself, and then probably doesn't enter the cranial vault, but probably separated a lot of the cord at that point. Transection cord injury that partly completely severs the spinal cord, and you can see that this is one of those lateral dislocation injuries, so that the nice thing about this is that depending, now where is this one? This is not so bad. This is L4-5, so you've got no cord there. But look at this guy right up here. Unfortunately, he's got L1-2, and there's still cord at that level. So probably cord got injured as well as the sacral plexus, and it'll get pretty well torn out there. If you get a complete transection of the cord of the cervical spine, you're quadriplegic. You're also incontinent because you've lost control of the bladder. And you have respiratory paralysis if it's high enough. If you're above C3, you've got respiratory paralysis. If you get spinal cord severing below T1, you're paraplegic and incontinent. Now you can have incomplete transection, which will give you one-sided weakness, one-sided paralysis, etc. Well, this is another one. This is another injury where you've separated the atlas and axis, and the DONS, that little finger-like projection, has done a pretty good job of probably snapping the cord at that point. You notice that patient is being ventilated. Now, if you have now you can have incomplete transections of the cord. Now, I mentioned before the anterior cord syndrome. What you get is anterior vascular disruption of the cord from usually from a flexion injury. The cord gets pinched anteriorly. You get loss of motor function and sensation of pain, light touch, and temperature below the injury site. But you retain vibration and positional sense, and you may retain motor sensation on one side of the body. Central cords syndrome is caused by hyperextension of the cervical spine, so extreme backward flexion of the cervical spine. Because that pinches the more central portion of the cord, if you have a hose and you bend it, it sort of kinks inward. Well, that pinches the center of the cord, and that causes motor weakness of the upper extremities, a little bit of bladder dysfunction, but you maintain lower extremity motor function. Doesn't affect your sensory, because the sensory pathways are on the outside of the cord, not in the center of the cord. The Brown-Séquard syndrome, these are obviously named for people. It's a penetrating injury, so you have to have a penetrating injury. Usually it's a knife, sometimes a gun, though, sometimes a bullet. And because the sensory, I didn't mention because it really wasn't important, but your sensory tracts come up usually 1 or 2 levels up the cord, and then they cross over and go up the opposite side. So it's kind of that's why if you have a stroke on your right side, you end up with left-sided paralysis. Stroke on but you lose sensation there because the sensation passes. It crosses. So in the Brown-Séquard syndrome, the penetrating injury, you end up with same side sensory and deep pain, or same side sensory, light touch, and motor loss, but you lose the other side of the body as far as temperature, sensation, and deep pain. So it's light pain, light touch, and motor loss on the same side as the injury, but you lose deep pain. You don't. It doesn't hurt, really hurt on that. So their arm doesn't hurt, but they can't move it. And you've lost the pains from the other side. So here's a cord compression, and you can see this. You can't find any fractures, really, but this was an extreme. Well, actually, there is a fracture back here, but he's completely squeezed the cord off, and you can see the cord just sort of stops there at that point. And so that'll be about T6, so he'll be quadriplegic and loss of bladder control. Okay, so general signs and symptoms of spinal cord injury. Extremity paralysis are probably the worst thing. Pain with or without movement. Tenderness along the spine. Impaired breathing if it's a high cervical, high thoracic spine. Or high cervical spine. Most people who get thoracic spine fractures or injuries also have, at least initially, difficulty breathing because it hurts to move the ribs, and that's why they're splinting and guarding their chest. But it's not because their diaphragm has been affected. If anything, their diaphragm is working just fine. Obviously, spinal deformity would be a good sign of a spine injury. Priapism, that's because you lost upper control of the sacral plexus, and so you'll have priapism. So half of your patients may show this. The other half won't because they're girls. Posturing. Because they don't have any control, any voluntary control, they will posture, which means they will be either in a they'll look like they have a head injury with extended extremities, unable to move. You may see evidence of loss of bowel or bladder control. That obviously, if they're incontinent, that means they have lost that control, and also decreased sensation. Spinal shock is a temporary insult to the cord. We see a lot of people who have hemiparesis, even hemiplegia, decreased sensation, and by the time they get to the ED, they're getting better. So that's spinal shock. Affects the body below the level of the injury. The affected area is flaccid. It's just like it's paralyzed. It doesn't have feeling. They may lose bowel and bladder control. They may have hypotension secondary to vasodilatation. We'll talk about that. But it's temporary. It may not come back right away, but it will come back over a period of time. Now, neurogenic shock occurs when you've actually got a spinal cord injury which has disrupted those descending tracts from the upper motor neurons, the brain, that are controlling your basic body functions. It's also called spinal vascular shock, but neurogenic shock works. You lose sympathetic tone because you've lost that spinal connection to those sympathetic ganglia. So you'll get dilatation of arteries and veins because of loss of sympathetic tone. That expands the vascular space. You've now got lots, you've dropped all your preload. So it results in hypotension. You've got decreased cardiac output because you've got no preload. Reduction of the strength of contraction through the Frank-Starling reflex as well, but also the sympathetic tone to the heart is gone. because you don't have sympathetic stimulation of the adrenal medulla, you can't make extra epinephrine or norepinephrine to compensate either. So you lost all the positive inotropic and chronotropic effects of the sympathetic nervous system. So the patient becomes bradycardic and hypotensive, which is not normal. You know, unless they were on a beta blocker, you wouldn't expect someone to be bradycardic and hypotensive at the same time. Your normal response to shock is to have tachycardia. So that's your tip-off. They will have cool, moist, pale skin above the injury because they still have sympathetic control above the injury. Warm, dry, flush skin below the injury because they don't have any sympathetic control anymore. So they don't have the ability to vasoconstrict the skin. Once again, we talk about priapism. It's an overrated phenomenon. Okay. Now, what about treatment of spinal injuries? Here's the big question. Long backboard or no backboard? The National Association of EMS Physicians, the American College of Surgeons Committee on Trauma have been doing lots and lots of stuff recently on looking at long backboards by EMS and the provision of spinal precautions. And one of the problems with using a long backboard is there's not adequate padding in it, and you end up with persons who might be immobilized for a long period of time in the emergency department or in the hospital before they get taken care of, which is not entirely your issue, but you know, we contribute to that. They get pressure sores, particularly if they're fairly large people and they're laying there without moving, and that is a decubitus ulcer on this person's buttock and sacral area. And let me tell you that trying to get that thing to ultimately heal is literally impossible. Now, I will be very honest and say that in 45 years, 38 years of emergency medical practice, I have never seen a pressure ulcer that I have attributed to the use of a long backboard. But that's because we're on the West Coast, where we actually go see people when they come to the emergency room by ambulance. They don't sit around on a backboard for days and weeks or days while they get treated. We see them fairly quickly, and we try to move them. You notice they try to get them off the backboard fairly quickly. But one of the problems with, still little old ladies, little old men who don't have much padding on their rear ends have a problem with it. People will complain about the backboard all the time. It hurts laying down there for any length of time. And if you're unconscious and laying there, you don't have any ability to do any wiggling around at all. So backboards have a problem. And looking through why do we use a backboard? Because we started using backboards way back in the 1960s. Way back in the 1960s, and there is no proven benefit of backboards. There's no scientific proof that backboards really do anything. Backboards cause pain, they decrease tissue perfusion, they get in the way, especially super immobilization on backboards makes it difficult to treat certain patients. Some little old people can't lay down on a backboard and breathe normally. Some people with severe arthritis, kyphosis, all sorts of things, you can't make them lay down on a backboard. It just doesn't work. We know that. So the committee, after digging around through all this stuff and looking at all the literature and doing all the talking and sort of yelling back and forth, their consensus opinion was that the use of the long backboard should be very judicious, i.e. the benefit should outweigh the risk. And they felt that there were only certain patients that were appropriate for long backboard immobilization. Blunt trauma with altered level of consciousness. Patients with obvious spinal pain and tenderness on examination by you or by me. Patients with a neurologic complaint, weakness, tingling, numbness, paralysis. Someone who has anatomic spinal deformity. When you log roll them, feel their back, they've got a step off, you've got a problem. A high energy mechanism of injury with any of the following, any one of the following. Intoxication, and that could be with drugs or alcohol. Inability to communicate, so you're stuck with the Russian national, the Laotian national, the Cambodian who cannot speak English to you because you can't communicate with them. Dementia follows into that. Hard of hearing falls into that if you can't communicate with them. If a guy can't move his arms, it's really hard to have them communicate with you if that's the way they speak. Distracting injury. Now, what is a distracting injury? Something that, in your opinion, would take away, would confuse the issue for pain. So somebody's got a broken arm, may not be able to tell you that their neck hurts also, or you can't adequately discern the difference. Now, immobilization on a long backboard is not necessary if the patient has a GCS of 15 and is not having any problem with this, if they have no spinal tenderness or deformity, no neuro findings or complaints, no distracting injury, and no intoxication. Furthermore, a patient with penetrating trauma and no obvious evidence of spinal injury should not be immobilized on a long backboard. Problem with this is that you need to do other things to take care of that patient, and you often cannot when they're immobilized on a backboard with C-collar and all that, and they're difficult to manage, and you'll get into trouble and you won't know it, and they'll die on you because you can't adequately assess and treat them. It turns out that most traumas, if you get a gunshot wound to the neck, gunshot wound to the chest, knife wound to the neck, and they don't have any evidence of any weakness, paralysis, or anything, that's not the problem. You're not going to cause them, but you don't have to immobilize them full bore. So for those patients who don't need to be immobilized, those few patients that do need to be immobilized on a long backboard, the ones who do not, they should have spinal precautions with the C-collar, and then just a nice ride on a gurney with normal strapping to, protection for the gurney. So people who are ambulatory at the scene, even patients who require long transport, interfacility, patients where the long backboard isn't even indicated, but you want to minimize movement and just do some attention to normal spinal precautions, but you don't have to go to the extremes. Yes, dear. Uh-huh. Mm-hmm.
Are you talking drugs in car accidents or drugs that fall down into their face?
Well, we'll kind of get to that. I think it'll be a little bit more obvious. For a normal drunk, normal age drunk, yes, we're talking about high energy, falls more than 20 feet, a crash in a motor vehicle, falling off a motorcycle, that kind of stuff. For old drunks like me, if you're more than 65 and you do a face plant, there's a significant number of people who are going to have spinal cord or head injuries. So age works into this. Yes.
I ask you this question about every 8 years, so we're due. How about, I've always been a little troubled by you have a toddler with some neck pushing on all the restraints. I've always been much happier having them calm and still than tying them up. That was always been my work.
I agree. It depends on your mechanism of injury. Now, if you've got a toddler that fell, out of the second story window, that's different than one who falls down, who falls off a chair or a table at home. If you get a toddler who's unrestrained in a motor vehicle, that might be entirely different. Especially if there's significant mechanism of injury there. But I agree that I would. You could do you could restrain a child in without going through the entire cervical, putting them on a little backboard and putting them on all this sort of stuff. I don't think that's necessary, and I agree. I'd rather not have them thrashing around or fighting you.
Would it be appropriate to use their car seats and then just kind of take their head down to that?
Often that's a great way to transport them. Sure. Now, my question is, why weren't they in the car seat to start with? Yeah. Okay. So, your rapid focused trauma assessment for likely spinal cord injury, you have to have you have to raise your index of suspicion for people 65 years and older. And some people will argue 55, and it sort of depends on the person. You have to make sometimes you get to make some judgment. There are some 65-year-olds who look like they're 80. There's some 65-year-olds who look like they're 40. So you kind of have to juggle that thing. But as a general rule, have a higher index of suspicion for injuries from falls and high-impact injuries for patients who are more than 65. So when the old guy falls off, the first robin of the fall, when he falls off his ladder because he's been cleaning his gutter, and that's not a 20-foot fall necessarily, maybe a 12-foot fall. If he's 65 or older, have a high index of suspicion for spinal cord, and be a little bit more careful. Multi-system trauma patients, because they're much more difficult to evaluate. Evaluate for deformity, neck deformity, pain, crepitus, warmth, tenderness, bilateral extremities. Just see if they can abduct and adduct their fingers. That's a quick test. Pull, push, their grip strength, motor and sensory function, make sure they can move their feet up and down, and their hands, make sure they have some sensation. That takes a second to rub their leg and see if they can feel it. You can, if you want to get fancy for me, you can say, well, he's got sensation above his nipples, so I guess he must have an injury at about T1, T2. You don't have to be that excited. You could do Babinski if you want. I would prefer you just check for ankle clonus. That's quicker. And then hold up position to see whether you can keep the arms up. Body temperature, we will check above and below the site of injury. You're not going to do that. Pulse, blood pressure, respiration, basic ABCs that you have to do anyway. And then ongoing assessment, recheck the initial and check your vital signs frequently on the way in, and recheck for any neurologic changes or deviations. Patients should be in a neutral inline position if possible, otherwise known as the position of function. Hips and knees should be slightly flexed for comfort, and it puts minimal stresses on joints. Put a roll blanket under the knees, support the head and neck. There's no contraindication to a neutral position unless the movement causes increase in pain. And about the only time you're going to get that in the cervical spine is if you get a partial dislocation or subluxation of a joint, because then they'll end up with a torticollis. They will have extreme resistance and difficulty to try to move it back. Don't do this. If they can't move it back, just fix them in position. Now that one would be one that I would put in a long backboard because they obviously have severe neck distraction and discomfort. And you could put your blocks on both sides and not worry about putting them in a cervical collar because you're not going to get a cervical collar around it. If you get resistance during trying to get them in the neutral, don't do it. If you have increase in neurologic deficits during movement, don't do it. And if they have a gross deformity of the spine, don't do it. Less movement is better. I can also tell you that I have never identified a patient from the field that we made a difference in putting them in midline position. You know, there is some movement of the cervical. There many times I think that you can probably do some movement of the cervical spine for intubation of the patient, even if with a cervical spine injury. But we aren't going to quite go there yet. If the patient has neurogenic shock, bradycardia, hypotension, fluid challenge first. You know, you're trying to fill up that vascular compartment. So 20 mils per kilo. Start out with 250 initially. Now, some of these people might go to congestive failure, but probably not. But give them, you know, better to give them 250 cc aliquots and, you know, keep going. If they probably will need to have a sympathetic agent to maintain adequate blood pressure and heart rate. So dopamine would be good for titrated for blood pressure, atropine for heart rate if they're extremely bradycardic. You're just going to knock out the vagal stimulation. You're not going to increase sympathetic stimulation at that point. Sedatives for anxiety and calming the patient. Midazolam would be the best thing, but you may have to obviously paralyze and intubate the patient if they're not able to manage their airway. Now, this is the Clark County EMS spinal immobilization algorithm. We have been using this for about 15 or 20 years now. The interesting thing is, when I went through all the literature that the American College of Surgeons and the National EMS physicians and all the other people Mark and Dave Seabrook and I co-authored a paper almost 20 years ago now using this spinal. And basically, we just published it saying, yes, we could teach paramedics to do this, and yes, it did decrease the number of people that went on long backboards, and yes, no one in our study had any spinal problems if you followed the algorithm. And this is now one of the main sources that they refer to in all these literature research, because, you know, who else has written about it, I guess. But so it still works, and this still works well. And this is the straightforward thing. Consider mechanism of injury. So falls, motor vehicle, struck with an object, pedestrian struck, an assault, bicycle accident, industrial injuries, falls generally, or being thrown by a machine, diving, drowning injuries. Always suspect if there's any drowning that there's cervical spine injury too. Boating accidents, patients greater than 65, higher index of suspicion. So first thing to check, patient mentation. Is there a decreased level of consciousness? Was there alcohol, drug ingestion? Was there loss of consciousness? Subjective assessment, cervical, thoracic, or lumbar spine pain. Numbness, tingling, burning, weakness. Objective assessment, deformity or tenderness of the cervical, thoracic, or lumbar spine. Are there other severe or distracting injuries? Pain with cervical range of motion. If the answer is yes to any of these people, immobilize. Now, if it's a very low suspicion, and you say, well, the patient had a loss of consciousness, but now they've got a GCS of 15, there's no drugs, alcohol, no other distracting things, no deformity, et cetera, I don't really want to put them on a long backboard. Then I would put them on a gurney and put a cervical collar on them. Bring them in. If it's no to any of these above, they don't need to be. If you're going to do a long transport, yes, then you put them on a gurney with cervical spine. If they have no other findings, you don't have to do full spinal immobilization for patients who have none of it. These people have always. Now, the only times we've erred in this is when you don't go through the questions, particularly the distracting injury. Because some people don't consider that a fractured arm is enough to distract from your neck. I can tell you it is. Some people don't consider. Actually, little old people are the ones that get me. I mean, the 85-year-old lady who said to one of my partners, also said to the paramedics who brought her in, said, when they said, do you have after your car wreck, do you have neck pain? She said, well, no more than usual. She had a fracture at C2-3, C4-5, C7, T1, T2, and she ultimately died of her cord compression from, not because we didn't do anything, we were on her at like proverbial everything when she got to the ED, but she ended up with cord compression from cord contusions and squeeze. So, and she had no more pain than you because she had arthritis. Little old people think that the arthritis, that pain is normal. Uncomfortable things are normal. So, and people who are not entirely bright will often downplay their pain. Children downplay their pain because they don't want to be in trouble. They don't want to go to the hospital. They don't want to be with the doctor. So if you follow the algorithm, it works. And it's worked well for many, many years. Okay, somewhere here, I have my other thing. Oh, good. He's got it right on. Okay. Okay, we have a couple of case reviews here. I'm going to run through, and I think we might, I don't think we'll offend anybody. I want to bring up, so I don't forget it, I want to inform you of something happening on Friday. A group of us, and I would welcome anyone who wanted to volunteer for this. We have a number of people already volunteering. We are going to be teaching hands-only CPR to the junior and senior class at Evergreen High School. We need to assemble about 9 o'clock and be out of there. We'll be out of there by 11. We're going to try to train between 800 and 900 kids in an hour. This coming Friday, the 17th. We'll also be covered by media. This is part of my desire and the EMS Council's desire to see more citizen CPR out there. And also, it's a reflection. I don't know if you guys have followed the state legislature much, but the legislature passed a law this year that has been signed by the governor now that will mandate high schools to teach their students. By 2017, they need to be taught CPR and AEDs as a requirement for graduation. Of course, it's true of the Washington State Legislature. It's an unfunded mandate, so there's no money in there to do that for the schools. But we're going to offer the schools to do this. But one of our problems in the county, our out-of-hospital cardiac arrest record for last year now for our survival rate, remember that's survival to go home, in a good neurologic condition, is just under 16% overall. For ventricular fibrillation, it's about 35%. Now the problem, I think the whole here is that when people call in to dispatch and they say, does anyone in the house know CPR when they think that's a cardiac arrest, 95% of the people say no. So we just don't have enough citizen CPR. We'll start with the kids. They can carry it on from that point on. And we get 10,000 kids trained in a year's time. That'll probably mean that we get 30,000 trained in 2 years, because we'll get some adults trained along with that, because the kids will bother the adults and make them learn it too. Hands-only CPR can be taught in about 4 minutes. Down and dirty, it's easy to do. So we're going to start with this one over the summer. We'll do some trainings probably at the mall, maybe down at the Saturday market, and then once again in the fall start going, and then also at the open houses at the fire stations, and we'll continue to move to that. AMR is having a national project to teach CPR. They're going to be, we're going to be participating in a little joint venture with AMR on the 22nd, which is EMS Day, at Fort Vancouver at a health fair they're having. At any rate, if any of you are interested, we probably could use a few more volunteers for Friday. It will be media covered. You get your chance to get your picture taken, I imagine. And we will go on from that. But my goal is to have between 30 and 45,000 people trained in CPR within the next 2 years, which means that your chances, my chance when I go down with my sudden arrest, is going to be improved. Yeah, otherwise, all I got to fall back on is Mark, and I can't bet on that one. Okay, case one. Arrived at residence, find patient lying supine on the floor, pulseless, apneic, and appearing cyanotic. Patient's wife stated the patient woke that morning appearing normal, no complaints. Walked upstairs to the kitchen, and then she heard a thud, called 911, and was provided CPR instruction because she didn't know CPR either. No recent injuries, etc. So here's our case. Obvious arrest, chest compressions are begun, bag valve mask. Paramedic interpreted the rhythm as being ventricular fibrillation. Chest compressions, again, defibrillated number 1, blood glucose 118, vascular access was gotten, chest compressions continued, defibrillation number 2, got a easy, didn't get vascular access, so an easy IO went in. Epinephrine given, suctioning, continued to do compressions. PEA was interpreted the next time. Medication, chest compression continued, EKG, intubation, suctioned, copious secretions, defibrillated number 3, lung sounds, epinephrine given, chest sound, capnography, epinephrine again, epinephrine, capnography, ETCO2 is 9, chest compressions, Let's see, what else did we get in here? Okay. All right, guys, what's missing in this? Helps. Okay. This one was the ALPS kit. This was a patient with the ALPS kit was in the AMR rig. This was a Clark County Fire and Rescue non-paramedic crew. They don't have ALPS. So the kit was not taken in. They did have the defibrillator, did have a unit, but the kit was not taken in. The other thing is they don't have the ability, if you don't have your own monitor on as well, you have to steal their monitor so we can download the PCO file. So this one was example. So the take-home message here. So this is an ALPS miss, because it would have been a good ALPS case, and we need to get as many ALPS cases as we can, not just us, but around the country, in order to complete the study within the allotted time period. So we're kind of crabby about missing cases that would fit. And you say, well, this patient was left at the scene. Well, it doesn't make any difference. That's not what ALPS is about. ALPS is about getting the data to evaluate that. Plus, all these cases get turned into the epistry, and we look at all these cases for our CARES out of hospital cardiac arrest thing for the state. So the take-home message is take your own kit in if you're with Clark County Fire and Rescue. Remember, Clark County Fire and Rescue is now moving up into Woodland and lower end of Cowlitz County, too. Now, next case, 51-year-old female. After her appointment with the chiropractor for her chest pain and adjustment, stopped at the fire station for help because it wasn't getting better. Patient went into cardiac arrest at that point. Pulled from the car, initiated CPR, got 2 shocks, CPR and IV prior to AMR's arrival. And the patient was transported to Legacy. So defibrillation 1, defibrillation 2, and then got amiodarone. And got epinephrine, defibrillation 3, defibrillation 4, is transported, begins en route. Well, she gets pulses with minimal blood pressure, and en route gets blood pressure, pulses, was unable, might say, well, this is a return to spontaneous circulation. Was hypothermia started? Well, no, because the refrigerator was out in the little unit, so there was no chilled saline. Patient was not intubated because they were able to ventilate and decided that they were only 3 to 5 minutes from the hospital, and so did not intubate. What's wrong with this case? ALPS kit was not used. What was the reason for ALPS kit not used? Forgot. What's the other thing wrong with this case? Mm-hmm. You know why the patient is to go to Southwest when they have return to spontaneous circulation? Because Southwest is the only one that has 24/7, 365 cath lab. Almost all these patients go to cath lab within hours or minutes of arrival with the return of spontaneous circulation, because there has to be some reason for them to have gone into their cardiac arrest. We will take patients to the cath lab even if they don't wake up, We take patients to, and this one, I believe, had a 12 lead which showed probable STEMI as well. This patient did survive, I think, but we don't know because one of the other things, I have difficulty getting information out of Legacy. What?
They got transported to Southwest that same.
Oh, good. Well, then they went to the cath lab then, because that's why they got transported to Southwest, is because Legacy won't, Legacy cannot do emergent cath lab. So we assume that she probably did reasonably well but just had an extra trip. Okay, so your protocol for ventricular fibrillation, pulseless VTAC. Initial intervention, identify absence of pulse and respiration, continue CPR for 2 minutes. If they were on witness arrest, defibrillate. A witness arrest, quick look, determine VFib or VTAC, and defibrillate as quick as possible. Unwitnessed arrest gets 2 minutes of CPR before you do the initial evaluation. In the ALP study, any non-traumatic cardiac arrest with persistent VFib following one or more defibrillatory shocks. So they need at least one defibrillation, and then they need to come back in ventricular fibrillation at any point in the thing. That is recurring or persistent VTAC. You need vascular access. An IO is great. You can't do it on people who are pregnant, kids under 18, prisoners, patients with known allergies, etc., to amiodarone lidocaine. No study bracelet. Has anybody seen one of those yet on a cardiac arrest patient? I haven't either. Usually they chew it off just before you arrive. If the ALPS vial is broken or damaged, you have to stop the administration and go to your standard treatment at that point. That's the only thing. With each drug, you do CPR for 2 minutes, analyze and defibrillate. Now, it is possible, particularly if you want to be in a hurry, it's perfectly acceptable to give the epinephrine and the amiodarone in the same IV sequence, one right after the other. You have to clear the tubing, that's all.
You all knew what you meant.
Okay. Epinephrine is given every 3 to 5 minutes as usual. If they have recurring or continuous ventricular fibrillation after the second or third shock, you can then give the ALP syringe, and the dose is ALP syringe 1A and 1B, the 2 syringes. Do 2 more minutes of CPR and reanalyze. If they are still in or back in ventricular fibrillation, give them another shock, and then you can give them the second bolus, so syringe number 2, which is 1 syringe only of the ALPS drug. And then you just continue that. You can also, if you used all your ALPS drugs, you can go to magnesium if you want another antidysrhythmic. If ROSC is obtained, maintain an O2 sat of 94 to 96, ETCO2 of 30 to 40 on the monitor. That first patient, by the way, had a CO2 of less than 9, which is where they called it. Notify ROC of the enrollment. Let the hospital know when you bring in this was an ALPS patient. We need to know the usual information on the PCR, but including the ALPS syringe number, the shock number that the ALPS kit followed, the drug kit number. Don't forget the ALPS has to be given with that adapter, that ClearLink adapter. The reason is it'll plug your ports. There's a little pin inside that glass syringe that ends up plugging the port if you don't use the ClearLink adapter. The CPR process file has to be uploaded that'll be taken care of at your agency. I'm sure you already have information, you've been looking at this stuff. All of your, we always usually talk about the hyporesuscitation, the rock study for we have stopped. That was a preliminary study to see that if the protocol would work. They may come back with a full study in the future, but all of your hyporesus things have been pulled off the rigs now, so you shouldn't have any little boxes that say rock hyporesus. They've been pulled off. They may come back now because we've proven that yes, the protocol does work. It is possible to do this stuff, so they may come back with the full study. My guess is they will not. They're going to substitute another thing for that one, another thing that'll work. But I've been wrong before in second guessing these two smart people. Okay. 59-year-old female, this is the last case, found unconscious at the bottom of the stairs per husband. She had about 5 glasses of wine and then fell down the stairs. He's performing chest compressions on arrival. She's unconscious, severe facial and head trauma, copious amounts of blood covering the entire floor, a 1 by 2 inch depressed skull fracture, obvious on her forehead with heavy bleeding. Pupils are equal, fixed at 4 millimeter. Raccoon eyes. Nose is deformed. Throat's unremarkable. Chest, no trauma noted. Expansion bilateral. Abdomen distended. Heart rate was 44. Hence the question about CPR. Initially 79 after airway was established. Blood pressure is 91/44. Respiration's 12. ETCO2 is 39. So she gets intubated, confirmed by waveform detector, ETCO2. Got some midazolam for sedation. Her capnography is initially 27. Pulse ox is 95. Blood pressure 84 palped. Pulse was up now to about 80. Capnography rose to 32, which is not a bad number to keep her on with that head injury. Blood pressure's 96. Probably could use a little fluid. Got some more midazolam. Now her capnography is at 36, about perfect. So, major face plant apparently, plus, obviously she went into cervical spinal precaution and a long backboard, appropriately on this one. Here's what she gets. She has a right frontal laceration scalp hematoma, fractures C1, C5 through C7. She had a Lefort 2 fracture. You know what a Lefort fracture is? It's a disruption of the face. It's an incomplete facial one, but you grab her upper teeth, pull out, and the face comes out at you. So, now, face the maxilla only. If you get a Lefort 3, which is a complete one, goes up through here, pull like this, and everything sort of comes out toward you. She had a sphenoid bone fracture, a right frontal fracture, comminuted pterygoid plate, so that she's got a basilar fracture through a couple of different bones, right orbit blowout fracture, nasal bone fracture, fracture T1 through T8, first, second, seventh, and eighth rib fractures. So she had facial repair, T1 to T4 fusion, slow improvement of neurostatus, initially lower extremity paralysis, She has a cord contusion because her paralysis is improving. She's now discharged to a rehab unit, has some difficulty eating and swallowing. That's mostly probably from the facial stuff. Happily, her C1 fracture is not the kind of, obviously the atlas got fractured, but it was fractured through a ring and not through the C2. The Dons is intact. C1 ring fracture won't kill you, usually. So this is a remarkable, good result from a major face plant. We don't know how far she fell. But with good treatment at the scene, which meant intubation, controlling your airway, and that's going to be a difficult airway to intubate because you obviously can't wiggle that neck around a lot. So, and that did well. It doesn't appear from my reading of this that she got suctional choline either. Looks like it didn't need it, which means that if a patient is significantly depressed in her LOC, you may not need to. If there's no gag reflex, you won't need to intubate her. I won't need to paralyze her. So, okay, a good time was had by all. All right. For the paramedic class, can you be back at 12:30? I'd like to start at 12:30 this afternoon. Okay? Good.